Good evening, everyone, and thank you for joining our open day event. And we are just going to give it a couple of more minutes for everyone to join. And I hope you will enjoy the presentation. And after the presentation, we will have a Q&A session. And myself and Dr. Sami will answer your questions, and hopefully the session will be interactive. And my suggestion is, if you could maybe put in a chat maybe your name and where you're dialing from, and your questions, and what you are interested in. And we're going to go through all of the questions at the end of the presentation. And yes, and hopefully, you will enjoy it. I think it's just 1 minute past. So Dr. San, we are going to give 1 more minute, maybe or two, and then we will start.
That's fine.
How is your evening going, Dr. Sami?
Yeah, it's good, thank you. How about yours?
All good, all good. I'm just enjoying the life with my puppy, 4.5 months, and
Keeping you busy, I'm sure.
keeping me busy. Yes, that's true. I think we just have more people joining. And yes, so yes, welcome again to our open day event. And I hope you all had a nice day and good start of the week. And we will perhaps kick off and start the presentation, if you don't mind, Dr. Sami. And yes, and again, I will encourage you, if you could type in the chat your name, where you're dialing from, and maybe any questions you have or anything you would like to ask us, please feel free, and we will answer all of the questions afterwards. All right, so let's go. So welcome to Plan Your Baby, so our open day event. And today we will discuss not only the clinic settings and how we work, how we help patients, but also we will talk about the possible treatment options, and we will touch the bases like non-invasive approach, IVF, and we will also talk about the pregnancy monitoring. And Plan Your Baby is a telehealth clinic. We are providing a full range of services nationwide. We do have more than 450 locations across the country. So that said, that means that we can actually help you regardless of where you're located. And we can offer the treatment in a very seamless and less stressful approach. Dr. Sami, would you like to go to the next slide? All right, so tonight we have myself. I'm by the background fertility nurse specialist and also nurse sonographer, and I have spent now nearly 15 years in fertility field, and I'm also founder of Plan Your Baby Clinic. And tonight with me is Dr. Sami, our medical director, and Dr. Sami has more than 20 years of experience working in fertility field and providing treatment for complex conditions like low ovarian reserve, reproductive immunology, recurrent miscarriages. So we will discuss all of the possible treatments, how we can help you if you are in this situation. And we have Catherine with us, our clinics manager, and she will help us to monitor your questions. So don't be shy. Start to type your questions. And unfortunately, really, she is unwell today, but you can meet her at 15-minute calls if you book. All right, Dr. Sami, would you mind to go to the next slide? Okay, so I think I would start just with perhaps the approach, what we take and how we start your journey. So at Plan Your Baby, we do always start with initial consultation with Dr. Sami, where your medical history will be discussed, and the consultation usually lasts between around 45 minutes to 1 hour, and we try to review all of your previous medical history, your previous results. And then at this stage, we will identify what investigations perhaps might be needed if you have not done any. Now, the next step would be after you've completed your investigations, which can be a set of hormones, including the AMH, the hormone profile. Perhaps the ultrasound scan is something that is recommended if you have not had one within a year. And for some patients, it would be important to check the tubal patency test as well to make sure the tubes are not blocked. And we also do all of the necessary investigations for males as well. So we do the semen analysis test, we do tests like DNA fragmentation and hormone tests, depending on the medical history. Now, once you have completed your investigations, the next step is for Dr. Sami to review them, which usually happening on the same day once we receive the results, and we will make a treatment plan. Once the treatment plan is made, it will be shared with you, and usually you would have a consultation follow-up with Dr. Sami to discuss all of your investigations. And then afterwards, we start to prepare all of the necessary steps like medication support. We can schedule a nurse consultation at any time that works for you to discuss the plan or answer your questions. And then the final step would be, if you are happy to start the treatment, is the consent completion, and we start the treatment. So, Dr. Sami, I will let you to take the floor and talk about the possible treatment options we offer.
Thank you very much, Maria, for that introduction. Yes, so just go through possible treatments that we can offer you at Plan Your Baby. So the first one, we call it assistance with conception. It's also known as ovulation induction. And this is where we stimulate the ovaries gently, usually with tablets, to try and help either people who don't ovulate, for example, women with irregular cycles, PCOS, for example, or sometimes we try and create what we call superovulation, where we encourage more than one follicle to grow. For some older women, that can be helpful. And that can, in some situations, be a good treatment option, which is not as difficult or as expensive, as risky as IVF. Of course, it's not suitable for every situation, but there are certain situations where we recommend that this should be where you start. And the process starts with period, and some women, of course, they don't get periods unless we induce period with some progesterone, so we can help with that as well. But once the period starts, then we like to check with a scan and blood test to make sure everything's good. Usually then I would ask the woman to take a certain dose of the medication. Letrozole usually is the first line, but we can use other drugs sometimes also to stimulate the ovaries. We repeat the scan and blood test around a week later to see how the response is. And if it's all looking good, then she will check for ovulation. And when there's an ovulation surge, we check the bloods again to confirm it's a true positive. And based on that, I will decide if there is going to be benefit from taking a trigger injection, or sometimes I just let the woman ovulate herself naturally. 5 days later, usually, we will check the progesterone. And if that comes back nice and high, then that confirms the ovulation, at which point, usually we will start the progesterone support, which will be progesterone pessaries. Then there will be a pregnancy test. And hopefully, if this woman is successful and she's pregnant, she will then continue support with us if she wishes in the pregnancy as well. This is a much easier, cheaper, safer option, but again, it's not suitable for every couple. So after taking the history and looking at the results, we can decide if this is a good option, or sometimes it's not something worth trying. Another treatment which we can offer instead of IVF, less common to be useful actually, but sometimes for some situations may be a good option. The treatment is called IUI, intrauterine insemination. And it's something which is very similar to what I described with the ovulation induction. It's pretty much almost the same process. But with ovulation induction, the difference is that the couple will be trying at home. Naturally, they'll be having intercourse every 2 or 3 days. With IUI, the timing is such that once there is ovulation surge, or we trigger the ovulation, we will then arrange for the sperm to be injected into the uterus. So both partners will need to travel down to our partner clinic in London. It's not something you can do just at home, so you need to travel to the fertility clinic. And then at the clinic, it's possible then to inject the sperm inside. But the rest of the procedure is pretty much the same. And I'd say the best situation, you can see the list of different possibilities to use it for, but the most successful patients with this are those who can't have intercourse, whether it's because they have difficulty, whether from the male or female side, these are the most successful, or For example, single women or same-sex couples, in this kind of situation, we see higher success rates. It's not very good for unexplained fertility. I know some people, they do it for that, or for mild male factor. But with my experience, I've not really seen very many success with that. And usually if you're able to have intercourse regularly, frequently, then it will be very similar success to IUI. So it's not something we prefer in those situations. And then we come to IVF. So IVF, it can be either because of female factors, it can be male factors. It's a much more involving process, much more expensive. It has a lot more risk, but for certain couples, this is what's going to give the highest chance of success. And yeah, there's a lot of people that we can help with IVF, where without it, they may not be able to succeed. It's a lot more monitoring with IVF. So again, we start with a period, doing a blood test and scan, and then the treatment this time will be injections, not the tablets, like I said before. So there'll be injections starting once a day usually, then it builds up to twice a day, sometimes three injections a day you might even end up taking. So quite a lot of injections. And you'll need a lot more blood tests and scans. So usually every other day we do a blood test and scan. And typically the stimulation is for about 10 to 16 days is the normal duration. So very involving, really. Every time there's a blood test and scan, the results are reviewed and the decision is made as to which medications to continue with, what dose. Everything can be very carefully adjusted and tailored because we don't want to give too much of the drug. Too much is not good for the woman's health. She may overstimulate and become unwell. It may also not be good for the egg quality. Too little of the medication, then we don't get as many eggs and embryos as she could get. So it's a fine balance to get it right. And that's why we ask for all these frequent tests so that hopefully we can do it properly. Then once the time is ready for the trigger injection, the couple will need to travel down to London again together for the egg collection procedure, which happens at our partner clinic in London. And embryo transfer, if they're doing a fresh embryo transfer, we've usually 5 or 6 days later is the most common time. But post embryo transfer, we will also monitor very closely. So we do blood tests every other day or every third day to check progesterone, because sometimes there can be dips in progesterone, and because of IVF, the normal mechanism which produces progesterone, the corpus luteum, isn't really a reliable source. We have to give extra progesterone, otherwise with IVF it's not going to succeed. And it's sometimes we see dips in progesterone, sometimes we need to top up the progesterone to make sure that that level is well maintained to give the maximum chance of pregnancy. And then once the pregnancy test is done, if there's a pregnancy which is positive, then we will again offer the woman continued monitoring to the pregnancy. We monitor the HCG, which is the pregnancy hormone, and progesterone quite closely for the first couple of weeks, and then we can do hopefully the first scan. So yeah, this is just to show you the post-embryo transfer monitoring. So we'll do progesterone tests. Usually there will be 3 times, sometimes 4, between embryo transfer and pregnancy test, so that we can adjust and tailor the medication. There can be some other IVF treatments, advanced treatments. So the normal IVF, fresh IVF, where we do the embryo transfer fresh, and using conventional IVF, where we put the sperm around the egg in addition, just allow it to fertilize by itself. There's IVF the same, but with ICSI, where we will actually inject a sperm inside the egg. So when the sperm quality isn't so good, usually this is what we do. And we select under the microscope and choose the best looking sperm and inject 1 sperm into each egg. And that can help fertilize the eggs, which may not fertilize otherwise. Some women or some men may not have good eggs or good sperm, or enough eggs or sperm, and therefore they need to consider if they want to use a donor, egg or sperm donor. And we can also do testing on the embryo. So instead of transferring the embryo fresh, we can look at the embryos under the microscope, but we don't know if they're genetically healthy. So we can do something called PGT-A, where we check for whole chromosome abnormalities. Or if the couple are carrying a genetic disease that we know about, we can do preparation and then test the embryos to see if they have any of these diseases, things like thalassemia, sickle, hemophilia. There's a long list of diseases which we can then help reduce the risk of their children having a significant health problem. So the difference between IVF and ICSI, the difference is that basically we will not need to inject the sperm if we're doing conventional IVF. We just put them around the sperm put around the egg in addition, left overnight to fertilize in their own way. But with ICSI, we have to use the needle to inject that sperm inside the egg. And typically we do it, the most common reason to do it is for poor sperm. So when the sperm isn't at a good level, then that is the most likely reason why we do ICSI. So So you can see from this chart, I mean, on the table, success rates are very much determined by age for IVF, and also for natural pregnancy, it's the same, of course. And mostly that's because of a decline in egg quality. Egg quality is very much linked to the woman's age. And when we talk about egg quality, the biggest factor is the chromosomes, the genetic makeup of the egg. And because a woman is born with her eggs, she doesn't make new eggs. As she gets older, the DNA starts to break up, and then the quality will reduce, and therefore the chance of getting pregnant will be less, the chance of miscarriage, unfortunately, will get higher. And this becomes more rapid after the age of 35, but even more rapid after the age of 40. There's a much bigger decline and a bigger drop in the pregnancy rates. So yeah, there's various different situations where donor eggs or donor sperm may be needed. It's usually to do with either poor quality eggs or sperm, or not having eggs or sperm as well. These are all certain conditions. And yeah, there's many situations where we can see this. For the donor eggs, the most common indication is age. So older women, 45, 46 plus, most of the time, if they want to be successful and have the best chance, they would go for the donor eggs. And then hopefully, if we see a woman pregnant, or sometimes we do this for natural pregnancy, where a woman has had history of miscarriage and she wants to have extra steps, extra monitoring done during her pregnancy, then we can offer the pregnancy monitoring package that we do. And that will involve very close monitoring the first 2 weeks of the pregnancy. And usually we monitor very close to the first trimester. But the first 2 weeks, we will do blood tests and ultrasound scans every 2 or 3 days. We will do scans then usually for every 7 to 10 days from 6 to 12 weeks. And then after 12 weeks, if everything is looking good, usually we can start to relax at that point. And we can give various medications. Usually always I'll give progesterone support, but there may be other drugs like blood thinners, sometimes immune treatments we can give, depending on the clinical history and results. And we can do this again from locally, so we can do it from wherever you live. We have, like Maria had mentioned to you, many partner clinics across the country, so you don't need to keep traveling very far to be able to get this done. And if it's just a blood test, we can also sometimes get someone to take the blood from your home if you wish. Okay, Maria, do you want to take over?
Yes, thank you so much, Dr. Samia. I think my favorite part is always about, the treatments when we go through, and I can see we have many questions, so we'll dive into that part in a short while. And but just quickly answering as well some of your questions, I will describe how exactly we are different, and what exactly Plan Your Baby is offering different rather than any other clinic. Now, we are very unique in terms of the coverage and how many patients we can help. And I think last year alone, we helped more than 1,000 patients across the country from different cities, which really makes us feel very proud that we actually delivering the care to your doorstep. So in terms of location, answering this question, we have more than 450 partner diagnostic center locations across the country, where you will have your bloods taken, and sometimes ultrasound scan as well. And Plan Your Baby receives all of your results within a matter of starting from 20 minutes for the ultrasound scan, and blood test collected by our couriers, delivered to the laboratory, and we receive the results within a couple of hours. So we do receive the results same day, and especially during the IVF treatment, it's very important. And how we communicate with you is via the video calls or emails, or even the WhatsApp. And I think this is what really fascinating, what we discovered many years ago, that the burden that the process creates for the patients is the lack of communication, is the delays, how quickly you receive your results, how easy it is to speak to your nurse or a doctor. And we decided that at Plan Your Baby, we will change this, because when you're undergoing the treatment, it can be extremely stressful, and we don't want you to feel even more stressed just because you can't access the clinic or a nurse. So you can simply message us over the WhatsApp, and our clinical team will reply on your questions. And in terms of the calls or our working hours, so Plan Your Baby open 7 days a week, and we do work from very early in the morning until very late in the evening. and our nurse is always available to answer your inquiries. So don't be shy sending us an email or a simple WhatsApp message. Okay, and Dr. Sami, would you like to go to the next slide? Yes. So, and how the process works itself, when you have your consultation with Dr. Sami, then we will send you the next day the treatment plan and the investigations you need. And you then leave it up to our team to book all of your appointments. So we do take all of this hassle and stress from you. We arrange all of your appointments in the closest location where you live. And sometimes during the especially IVF treatment, we can send a nurse to your home to take the bloods, and our courier will collect the blood sample from the comfort of your home. The same we do with all of the necessary medications for the treatment. We arrange a medication delivery. The earliest medications can arrive is the following day, or for the day that works for you best. Because for some deliveries, we would require you to be at home to accept the medications. And then in terms of all of the consultations, you can actually book them yourself for the time that works for you. So you can choose what time you would like to speak to Dr. Sami or with a nurse. And the links provided when you start the treatment. So you will have a link to book a consultation with a nurse at any time you wish. And it can be done over the video call as well. In terms of the pricing, once you have a consultation with Dr. Sami, we're very transparent and you will receive a detailed plan for your treatment with zero hidden costs. And then we also offer a 0% interest rate payment plans. So you actually can apply for the payment plan and choose either you would like to have it for 1 year or a bit longer. So you will always have those options available. And when it comes to start the treatment, you just need to let us know if you would like to pursue this option, and our staff will send you the link for the application, which takes only day and sometimes less. Dr. Sami, would you like to go to the next slide? Yes. So in terms of the process, how it works for our patients, you speak to our nurses, you have a consultation with Dr. Sami, and then we will handle all of your appointments on your behalf, and we will receive all of your results to our system, which always shared with you as well. So you always will have your results available through the portal that you can access and review. In terms of the timing, so from your consultation point to start the treatment, it only can take a couple of days if all of the investigations are available. Very often, the treatment can be started with your cycle period. So that means depending on what stage you are now, we will have to wait for your period to start. Okay. And at Plan Your Baby, we also offer consultations with nutritionists as well, with psychologists to support you on the holistic side as well. And we also work with acupuncturists as well. So we know that some patients prefer to have acupuncture during the IVF cycle or even post embryo transfer. And our team then guides you through the whole process by holding your hand. Next slide, Dr. Sami. Okay, yes, so tonight we are having an exclusive offer for you. So for everyone who joined our webinar, and if you would like to speak to Dr. Sami, you have an opportunity to book the consultation with a 15% discount. And you can choose the time and day straight away just by scanning this barcode with your device. If you feel that you would like to take a short break and first to hear our answers, which we will go shortly, so we will go through the Q&A session, you can do that. And but otherwise, at the end of the session, we can return to the barcode to the QR code if you will, if you have missed it. Next, Dr. Sami. All right, so I can see that we have many questions, and I promise we will try to answer them all. But if you feel that we have not answered your questions, please don't be shy. We will put in the chat the email address, and also we'll put a link to our WhatsApp. So feel free to contact us. So, Dr. Sami, I'm gonna start because there is a list of. If you would, maybe Dr. Sami, yeah, if you. It's fine. I just want to maybe return to the QR code, but it's fine. So the first question, Dr. Sami, is the lady is trying to conceive, but she has not been successful yet. Unfortunately, there is no any timeline for how long she tried to conceive, but she is asking what tests she might need. If you could cover this question.
I mean, there are many tests that you can do for fertility, and it is always going to be guided by their history and any tests that have been done previously in the previous clinic or with a GP. We can also accept if they're recent and relevant. But in summary, for basic testing, we'd always want the old woman to go through an ultrasound scan, a pelvic ultrasound, to look at the ovaries and the uterus. There's also a set of blood tests. So we check AMH, which is a test for egg reserve. We check hormones, usually with the period, FSH, LH, estradiol, progesterone, prolactin. Thyroid function, usually I would check. And then for the man, semen analysis. And usually for both partners, I'd check vitamin D because it's very common actually to find vitamin D deficiency, and that does also affect the sperm and the egg quality. But the additional testing will be, based on the history. So there'll be a consultation, and then we'll see if there's any other tests that could be helpful and useful.
Thank you so much, Dr. Sami. We have another question. Hello, I'm Kylie and I'm from Cumbria, and I have been trying to get pregnant for 19 years. And she has completed one IVF cycle, but unfortunately it was a miscarriage. And since then she tried to conceive for a very long time, but unfortunately all pregnancies ended as a miscarriage. And it is very emotional. I'm so sorry to hear this. But anything, Dr. Sami, you can recommend? I know, unfortunately, we don't have a lot of information, but anything that you would be able to suggest?
Yeah, so I'm very sorry for you, Kelly. You've had 19 years trying, and even the IVF you did ended in miscarriage, which, miscarriage is always horrible, but when it comes following IVF, it's just so painful. And she's had, a lot of problems with this. Now, I'm not sure of her age, because if she's trying for 19 years, I'm not sure what age she is now. Hopefully, if the age is still 45 or under, there's still maybe hope. But definitely there is a need to move quickly, because with each 6 months or year, there can be quite a significant reduction in both the egg quality and embryo quality, and reduction in the chances for getting pregnant naturally or even with IVF. But yeah, it may not be necessary for IVF if she's getting pregnant naturally on her own. Sometimes we can assist with doing some blood tests, checking hormones, checking the immune system sometimes if there's recurrent miscarriage, and giving supportive medication once she knows she's pregnant, things like blood thinners, immune treatments, progesterone, following up with the pregnancy monitoring like I mentioned. And we do that for lots of women who have recurrent miscarriage. And yes, we can never prevent every miscarriage, of course. The most common cause of miscarriage is a chromosome defect, and no treatments are going to fix that. But at least we give a better chance by covering the other things that can be controlled. And then we just have to hope that she is lucky and she has a healthy embryo, and hopefully we can help it to get to 12 weeks. And if it gets to 12 weeks and everything is good and the screening is fine, then at that point, hopefully she'd have a very good chance for success.
Thank you so much, Dr. Sami. Another question. My name is Josephine from Leeds. I had an ectopic pregnancy about 2 years now, and since then I've been trying to conceive again, but it hasn't been successful. So the question is, what could be the problem? Thank you.
Okay. Well, I mean, it's difficult to know for sure. The ectopic pregnancy, sometimes it just happens as bad luck. Sometimes it's because there was a problem with the fallopian tubes, and one of the most common problems to cause issues such as ectopic with the tubes is there could have been some past infection. Sometimes it's something that you know about. You may have had chlamydia in the past or another STD which have led to problems with the tubes, because quite often that can happen. But also there can be more subtle infections that you don't really notice. You can just get a bit of tummy ache or something, and then actually have inflammation in the pelvis, which causes the tubes then to not work so well. And even if the tubes are open, we can test the patency of the tube. We can know if the tube is blocked or not. What we can't test is the function of the tube, because the function, there are little tiny finger structures called cilia inside the tube, and they have to push the egg and then the embryo into the uterus downwards. And if they get damaged, then that tube isn't working, even if it's open. And most likely you're going to get either ectopic pregnancy, or most likely you're not even going to get pregnant because the egg isn't going to be able to travel down enough. So it could be a tubal issue, maybe, but it could also be other things. So sometimes the uterus itself is not a very favorable environment for the embryo to develop. And I've seen some women where they had very high immune activity, and the problem was actually showing with repeated ectopics, because every time the embryo is inside the womb, it wouldn't implant and develop. It was only able to implant in the fallopian tube, but the blood flow is much poorer. So it's something that, yes, we need to explore. 2 years is quite a long time. Most likely, even if we do all the tests and everything looks good, most likely I would recommend IVF in the situation, because there's a high chance there could be issue with the tubes, and doing IVF will bypass the tubes for you.
Thank you so much, Dr. Sami. We have another question. I have PCOS and would love to try ovulation medication. And it's something that we call in our clinic assistance with conception. Dr. Sami, could you explain to us how exactly the treatment can help?
This is something we do a lot of, actually, ovulation induction, and I think it's a good treatment for most women with PCOS. Of course, we need to check everything else is good, especially the sperm, for example. If there's not good sperm, then this may not be a good option. It may be that you need to think about IVF. But for when the sperm is good, when the other factors are looking normal, just the PCOS, just irregular cycles, then this is definitely the first line treatment, the first thing they should try. And usually we try it for at least 3 cycles, and we can go up to a maximum of 6 cycles. Yeah, definitely something we can help you with. And if you're interested, you can book a consultation, and we'll take you through all the steps, and we can get started fairly quickly once you've done all the initial investigations. If you've done them already, even better. We can start even quicker.
So much, Dr. Sami. And just to add, we specifically for this treatment, almost 66% are with polycystic ovaries that present to us. So this is very, very, very common that we see. Another question, Nancy in London, been trying to conceive, but unfortunately it's been unsuccessful. Any treatments that you would recommend, Dr. Sami, for blocked fallopian tubes? I know you just answered the question, but the specific treatment that would be suitable?
So yes, I mean, in the past, when the tubes were blocked, the thing that would happen with surgery, tubal surgery, and surgeons will try and unblock the tubes. They'll try and cut open any blocked area, reattach it, because IVF before wasn't available, or it wasn't widely accessible. And the success rates are very poor with this, extremely poor, in fact. And it's a big operation. It's not an easy operation. Sometimes you can't even do it laparoscopy. You have to have a big cut in your tummy to be able to achieve this surgery. And the very disappointing thing as well that we saw was that a lot of these women who did tubal surgery to fix the tubes, and they did a patency test afterwards, which showed that the tubes were open post-surgery, 6 months, a year later, tubes are blocked, and they're back to where they were. So if they didn't manage to get pregnant at the time, or even if they did and they want to get pregnant again, that's it. It's gone now. They can't get pregnant. So the most common pathway now for people with both tubes blocked is to go for IVF, because with IVF we bypass the tubes. We don't need the tubes. And if that's the only problem, then usually we get very good success. As long as the woman is of good age, no other problems, then you should have good results with the IVF.
Thank you so much, Dr. Sami. Next question we have is about egg freezing. Do we offer egg freezing treatment? And if you could just explain how exactly the process is.
Yes, we do egg freezing. I think it's something which is becoming more popular nowadays, more awareness of it, and it's a good way, like I mentioned in the presentation, that as a woman gets older, they can be then decline in the egg quality and the egg numbers, and especially as a woman goes beyond 35, and even more so above the age of 40. So ideally, if a woman is going to freeze her eggs, she'll freeze before 35 or under. That's the best time, because that's when you have the best quality and the best number of eggs, and it'll be easiest to do it then, with the best chance of having a baby out of these eggs. Never guarantee of having a baby, but this is going to give the best chance. And the process is the same as the IVF. So again, just what I described for the IVF, the only difference would be that once the eggs are collected, then they are frozen. We don't need to worry about after giving drugs and doing tests after the egg collections happen. So you have your egg collection at the part of the clinic, and then your treatment is finished pretty much, and you will find out how many eggs have been frozen. And if it's a good number, then that's it. You're done at that point. If it's not maybe so many, then we can think about if you want to do it again. So it's something that we do. We did do a webinar 2 weeks ago, exactly. I think it was about 2 weeks ago. So maybe we can send you the link, or you can email us and ask for the link to be able to watch that, because it was a whole dedicated webinar just on egg freezing.
Thank you so much, Dr. Sami. And another question, which options are suited for females with a partner undergoing chemotherapy?
So ideally, before chemotherapy, it would be good if the man can freeze sperm before chemo, because chemotherapy can affect the quality of the sperm, the quantity of the sperm. If it's already undergoing chemo, then if he hasn't completed his course, he can still freeze sperm. But if it's post chemo and the sperm is not much, then we need to see how much sperm is there, what his hormones are like, kind of get a gauging of the picture. We don't need huge amounts of sperm to be able to do IVF with ICSI. So normally a man will produce in a sample of sperm millions of sperm, but with IVF or ICSI, we don't need that many. As long as we get 20, 30 good sperm, that's enough really for us to be able to fertilize the eggs that we collect. But if there's no sperm whatsoever, then that's a different situation, of course. We'll have to check his hormones. We'll have to refer to an andrologist, who's a male fertility surgeon, and look at the feasibility of maybe trying to get the sperm surgically. But there can be situations post-chemo where there's just no sperm and it's not going to be an option, and it may be that they'll have to consider donor sperm sample, but that's, again, going much further down the line.
Thank you so much, Dr. Sami. Another very interesting question actually. Dr. Sami, high blood pressure medications reduce the sperm motility. So what can be done to reverse it? And if you could actually describe what the impact actually medications can make on the sperm, because I don't think we talk a lot enough about this.
Yeah, so there are certain drugs which are not good for the sperm. The sperm production you can end up with reduced quantity of sperm or reduced quality of sperm, or sometimes both. And some drugs you will want to kind of see if there's alternatives, because with blood pressure there are many available drugs, and if there is an alternative, it's something you have to discuss with your physician, of course. If there's an alternative drug that you can try, which will also control your blood pressure without causing problems with the sperm, then okay, you should discuss whether it's worth switching to that. If not, maybe you've tried all these different drugs and it's not really working for you, and this is the only way to get your blood pressure under control, then this is the priority. Of course, you need to focus on your health as well. That's more important than anything else. But at the same time, there is a role to be played by taking some male fertility supplements, healthy diet, healthy lifestyle, avoiding heat, getting some rest. These were all things, frequent ejaculation as well, every 2 or 3 days. These are all things that can support the sperm and maybe help to improve the sperm quality overall. There are some men, even who don't take blood pressure medication, the motility is poor, and even if you stop the drug and you switch, it might not be that the motility improves. It's possible that it stays the same, in which case, if there's no pregnancy and the motility is very low, again, IVF with ICSI might be the best answer.
Thank you so much, Dr. Sami. Another interesting question. Dr. Sami, could you please help to understand what can boost AMH levels and also maybe equality?
Okay, well, this is a very common question actually, but AMH is a test for egg reserve. It's a test of number of eggs. It's nothing to do with quality, but it's also a vague test. It's not 100% accurate, and you could do an AMH today and it could be, for example, 5, and you could do it tomorrow and it could be 10. It's not going to go from 5 to 50, but it can be that it changes so much. And sometimes women get excited, oh, my AMH is going up, my egg reserve is going up. No, egg reserve isn't going up. It's just a vague indicator, and the test isn't 100% accurate. It's just giving us an idea as to what your egg reserve is, because unfortunately there's only one direction for the egg reserve, which is to go down as you get older, because you don't make eggs, you're only losing eggs with time. So there's no way to improve egg reserve. AMH, who cares if it goes up or down? What's more important is the egg reserve itself. There's no way to improve it or fix that. Yes, healthy diet, healthy lifestyle, avoiding especially harmful things. I mean, we had mention of chemotherapy. That's very bad for the egg reserve, of course. But there are other things such as recreational drugs. I've seen some women who abuse those recreational drugs even at young age, ended up with extremely low AMH. Smoking is not good, too much alcohol. So trying to avoid these things can help maybe reduce the rate of decline, but you can never boost the egg reserve or improve it. And then when it comes to egg quality, the biggest factor to do with egg quality, the age-related factor, is the genetic makeup will change and it will become abnormal. And if the egg is abnormal, then most likely that egg isn't going to make a healthy embryo, and it's not going to give you successful pregnancy. Even if you get pregnant, it's most likely going to miscarry. So this is, again, an irreversible change, unfortunately. You cannot fix eggs, not with diet, hormones, nothing. It's not something that can be improved. But like I said about the egg reserve, again, healthy diet, healthy lifestyle, taking the right supplements might reduce the decline, and it can maybe help with other factors which are not chromosome related to do with egg quality. They're not as important, I know, but still you want to have kind of every little bit of help.
Thank you so much, Dr. Sami. But I wanted to add here, I know we've been working with the infertility field for so long, and perhaps sharing some stories can be encouraging. I remember 5 years ago, maybe a bit less, 4 years ago, we had a patient and she was with the AMH maybe, if I remember, 1.2 or 1.3, so very, very low. And she was 37 years old when she came. And it was still at our, I think, well, maybe 5 years ago, at our previous work, when we worked together with the previous clinic. And she only had 1 IVF cycle, 2 eggs collected, and 2 embryos transferred, and she delivered twins. So just to encourage those that yes, AMH is a very important factor, and the ovarian reserve is can determine sometimes, or predict the outcome, but definitely the age and genetics means a lot, I think, in this situation.
Definitely. And a lot of people get too worked up about this AMH. It's not the most important thing. The
Yes.
quality is much more important. And like Maria just gave this example, you only need 1 good quality egg to have a baby. You don't need to have 20 eggs. So it's not the most important thing to focus on. And I think it's a bit difficult for some patients when they get their result and someone tells them it's very low. That's always very sad news, but I think maybe reading a bit too much into it, giving it more weight than it's worth.
Sure. We have more questions to go through. Now, another patient located in Bedford. We actually have a lot of patients from Bedford and Milton Keynes. And myself and wife, we haven't decided yet. We are both 40 years now, and we have 1 son, 5 years old. And now I assume they have not been successful since. Any advice you can give, or the reason for the secondary infertility?
Okay. So yes, I mean, this is what we call secondary infertility, where they had a child before. I don't know if it was easy or difficult to have that first child, but regardless, if you've been trying and at this age of 40 for 6 months or more without having any success and getting pregnant, then the recommendation is you start looking into tests, first of all, test for you and for your partner. Basic test to start with and see if there's anything, because maybe you will find that there's something which has changed in your body. Yes, you had a baby before, but sometimes things can change in your health and your body, which mean that now it's not going to be so straightforward. And of course, if we know what the problem is, it's much easier to direct treatment. Even if we don't find anything wrong, and it's what we call unexplained. I mean, the age factor is probably one factor which is there now, which will affect the egg quality, but still, it could be that you would consider IVF, and IVF, it's better to do it, like I mentioned, the younger you do it, the better chance you have. So if you leave it another year or 2, for sure the results are going to be lower, lower chance for you to have another baby. So that's, again, something that we could explore.
Thank you so much, Dr. Sami. We have another interesting question. I think it's a message coming from the gentleman. So himself and wife, they wanted to do IVF, but they were told that there is no view to her ovaries due to a large fibroids. Dr. Sami, anything you can recommend or a type of investigations or maybe your experience providing IVF in this particular situation?
Yeah, so fibroids, they're overgrowths in the muscle of the uterus. And actually, very many women will have these fibroids and not know that they have them. Usually they're small, usually they don't cause any troubles. But sometimes they can be big, or they can be very many fibroids, and it can distort the pelvic anatomy sometimes. And this lady, it sounds like she had fibroids which are pushing her ovaries up into the upper abdomen, because normally when we collect the eggs, we do it through the vagina. But if there are fibroids which are in the way and pushing the ovaries up, then that makes it difficult or maybe impossible to reach the ovaries that way. So there are two routes that can be taken here. One is that if there are many fibroids, if there's a huge uterus, then also there's risk in the pregnancy and so many other problems that can happen. And it may be better that she goes for surgery to remove the fibroids first. We call it myomectomy, which can be done laparoscopically or open, depending on the situation. And then that same surgery, they can bring the ovaries back down into the pelvis and then make it easier for future egg collections. Or sometimes it may not be that we need to do the surgery, but the ovaries are accessible through the abdomen, through the tummy. So instead of going through the vagina, through the skin and the tummy, it may be possible to pierce the skin with the same needle and get to the ovaries and extract the eggs that way. It's not as easy, it has more risk. Not all IVF clinics have experienced specialists who do this. Our partner clinic, they do actually have the experience to be able to do this for situations where it's needed. But yeah, it's not a straightforward situation. Again, each individual case is different, so we'll need to kind of understand a bit more about her before we can see what's the best route.
Thank you so much, Dr. Sami. Another very interesting question, and I know there is a lot of even speculations and so many advices, especially online. But Dr. Sami, anything that you can recommend from the supplement perspective for patients who are preparing themselves for IVF? I know it can be very individual, recommendations, but anything that you particularly think can help patients?
So every patient who's trying for a baby, whether IVF or not, should be taking folic acid, or even better if you get prenatal supplement, which will be a bit more complete. Every patient, I think, also should either check their vitamin D or take extra vitamin D, but you don't want to take too much vitamin D, so it's better to check, because vitamin D can cause toxicity, and if you do have toxicity, then this can cause problems for your health. If you don't eat much fish in your diet, I usually recommend fish oil supplements, omega-3. And then CoQ10, coenzyme Q10. This is another supplement which helps with the energy production within the egg. It's not established evidence, but there is some evidence that says that this may also be helpful. So I think that's also worth taking. So these are the ones that I think should be involved. Now, depending on certain tests and other things, we may add in other factors, but this is kind of the basic list.
Thank you so much, Dr. Sami. And I think if you also would like to know more about the list, or you did not have opportunity to write it down, just let us know and we can send you the list of supplements. Dr. Sami, another question. The menstrual cycle has stopped since last year and AMH is low. Is there a way to treat me to have good quality for IVF? Ladies 45 years old.
Okay. All right, so this is a little bit of a difficult one, I'm afraid. I'm not sure that we can do much for this situation. It sounds like she's having what we call primary ovarian insufficiency or premature ovarian insufficiency, where the ovaries are starting to shut down earlier. Normally, this happens a little bit later on, but at 45 years, even if there was good AMH, the bigger problem is the egg quality isn't good. Majority of eggs, probably 99% of the eggs will have abnormal genetics. So even if there was good egg reserve, it's still a difficult situation. But of course, now it sounds like she hasn't had periods and her AMH is very low. It could be she's in a perimenopausal phase, or maybe even menopausal phase, I'm not sure. There will need to be further tests like FSH, LH, estradiol checked to see what they look like, and that might give a clearer picture. But the other thing that is important is that if there is no egg reserve left, it doesn't mean that you cannot carry a pregnancy. The uterus doesn't age in the same way as the ovaries. So if you do have the option of going for egg donation, then there's still a chance that you can have a baby that way. And the egg donation is going to come from a younger woman's egg, and therefore you should have a good chance. Of course, I understand, not for everyone, not everyone wants to do that. But unfortunately for this lady, it sounds like she's in a bit of a difficult situation, if I'm honest.
Thank you so much, Dr. Simon, for your advice, and thank you for being so transparent. I think this is sometimes really needed. Another question, what happens if you have irregular periods with polycystic ovaries? This is me as well. Same
The
situation.
PCOS, yeah, it's very common, exactly. So, it's something we see all the time, because a lot of women with PCOS, they don't have regular cycles. There are some who do, but a lot of time there isn't regular cycle. There's hormone imbalance. And when there's no regular cycle, usually that means there's no regular ovulation. And if there's no regular ovulation, then it's not going to be possible to get pregnant. If you're not ovulating, you're not going to get pregnant naturally. So this is where we can try and help this woman. If the sperm for the partner is good, if there's no other factors, we can think about doing ovulation induction assisted with conception that we mentioned before. And that can stimulate the ovaries to hopefully produce the egg, and then they can try naturally and hopefully achieve a pregnancy naturally. But again, if there are other factors, sometimes we do need to think about IVF.
Thank you, Dr. Sami. I just will say that this is so familiar to me, and I remember when I was preparing for the ovarian stimulation, what really scared me is exactly the polycystic ovaries, how will I respond to medications, and yes, I did produce unnecessarily too many follicles, but not all of them were good quality. Dr. Sami, another very interesting question. And I also think that maybe we don't get too many questions, but it's very, very common condition. So what, Dr. Sami, change in treatment protocol would you use for someone who has adenomyosis and also very sadly had 5 failed IVF cycles?
Okay, so I'm very sorry for this woman. She had, 5 times without success. And yeah, adenomyosis means that there is a change that happens in the uterine muscle, the muscular layer of the uterus. It will become more vascular, become more thickened. It's inflammation. So it is linked to endometriosis as well, although there's not always endometriosis with that. And there is association between adenomyosis and reduced fertility, increased miscarriage rates as well. Now, most women who have adenomyosis or labeled as adenomyosis, actually it's not severe most of the time. I don't know for this particular woman, but majority of times where woman is labeled as having adenomyosis, it's not severe at all. And most of these women actually don't have difficulty in getting pregnant. The difficult ones are the severe adenomyosis, but even those who are severe, I've seen so many women with severe adenomyosis and they've been told you're probably not going to ever get pregnant, and I've seen so many of them get pregnant and have their own baby. Now, with this lady, she's asking about, what changes will be done, what protocols. It depends. I mean, I'd have to look at the 5 failed cycles in detail. So I'd need to have a copy of the notes, all the clinic notes, all the details, the protocols, the hormone levels, the embryo quality, all of this. Need to have a very careful look at to understand what is happening, what the problems may be, how our body responds. All of this is really important to look at and to try and learn from and see what may be adjusted and changed. Because I don't believe that there's one protocol that is for adenomyosis, which is very different to someone who doesn't have adenomyosis. I think certainly if there hasn't been investigation into the immune system, then that needs to be done. Hysteroscopy, if that hasn't been done, then that needs to be done. I mean, maybe she's done all of these things, I'm not sure. But there's no like adenomyosis protocol. I know that there are people who claim that you should downregulate where you suppress for 3 months, or even sometimes people done longer than that, suppress the ovarian function. So you create menopause basically for a few months, and that might help apparently, but I've not really seen good results with that when I used to do it a long time ago, and it's starting to fall out of favor with the recent studies that are coming out. So it's not as popular as it once was, but some people have tried that, and that is what their adenomyosis protocol is. But I don't believe that there's a one size fits all. Just because adenomyosis you have to do on this protocol or that protocol. I don't agree with that.
Thank you so much. Dr. Sami, if you wouldn't mind, I know we don't have much time, but just maybe give a few lines about how adenomyosis is connected to immune system.
Well, adenomyosis, endometriosis, all of these are chronic inflammation, so you can't really get rid of it. The only time it goes away is when you go through menopause, because they are linked to the hormones. And any chronic inflammation sometimes can be linked to the immune activity. And if the immune system is triggered by this adenomyosis or endometriosis, then it can be triggered in a way that can be unfavorable for pregnancy. And every time there's an embryo inside the uterus, it can be attacked, and then just very difficult to get pregnant, or pregnancy may not progress and you end up miscarrying. So not everyone with adenomyosis or endometriosis has this. I don't believe that at all. But they have a higher risk of having the immune problems, especially if someone has had 5 times failed IVF. You know, they're definitely high risk. So if they haven't done immune testing, that should be top of the list, really.
Thank you so much, Dr. Sami. I still see we have many questions, and I know that we don't have much time, but I want to ask you just a few more so we can answer as many as possible. But if you feel that we have not answered your questions, I highly encourage you, please let us know over the WhatsApp or email. We will come back to you. We also have those questions saved, so we will try to come back to you. Now, another question. My husband and I have been trying for 8 years and got pregnant twice, but unfortunately miscarried both times. So GP did all blood tests, said everything is okay. The lady is 36 and husband 43. I don't know which procedure is best for us, because we seriously want to get pregnant this year, and period is normal and regular.
Okay, so yes, this again, a very sad situation, long term, trying 8 years, 2 miscarriages. Unfortunately, still not pregnant. She's 36, which is still a reasonable age, which is good news. But I don't know, were these miscarriages recent, or they have been happening within the last year or so, or is it something that happened a long time and not managed to get pregnant at all since then? And then, yeah, I presume that her husband had a sperm test, but if not, then definitely that needs to be checked. Even if it's checked a few years ago, maybe recheck again, because sperm can change. But I think in this situation, we need to do probably further investigations than what the GP has done. So we need to see what the GP has done. Hopefully they've done, you know, quite a lot of good things, and that'd be great. But usually there are more tests that may need to be checked, perhaps checking the uterus, checking the immune system, perhaps even, you know, there are things that maybe the GP wouldn't offer that we can look at to see if we can find out what the problem is. But most of the time, I would say that the situation like this, where it's long-standing infertility, 8 years, not being successful, probably IVF is the best option. Even when it's unexplained, even when everything looks normal, with IVF, we still get good results. And especially because she's at an age now, she's 36, so she's still a good age, but if she waits another 3-4 years, then it may not be so good situation. So if you're going to do IVF, it's better not to leave it too much longer, really.
Thank you, Dr. Sami. Please forgive me, but I'm going to use every minute we've got left for another question. So for someone with everything normal on both sides, apart from abnormal IgG levels on repeat blood tests, how do blood thinners help? And should we try this, as we've always been told to do IVF cycles and not given blood thinners before?
IgG, is it for, did they mention what for? Because IgG could be very,
Unfortunately, no, I can't see, but maybe it could be antiphospholipid.
if it could be, I mean, yeah, that's what I'm thinking. If it's anticardiolipin antibodies, then, or you know, lupus anticoagulant, or anything which is part of the antiphospholipid screen, beta-2-glycoprotein, if they're repeatedly positive, then yes, this could be something which impacts your chance for getting pregnant, as well as for keeping pregnancy. It's actually more common to have the miscarriage, a picture from this, but sometimes I've seen some women where they actually need some blood thinners before getting pregnant, even. So post-ovulation, we can start it in some situations. Definitely during IVF, for sure, 100%, you should take the blood thinners during the IVF cycle, before the embryo transfer, post-transfer, and into the pregnancy as well, when there's anticardiolipin. It's really important.
Thank you so much, Dr. Sami. I know we are running out of time, but last short question, promise, my last one, and I will encourage everyone then to contact us by email or WhatsApp, and we will try to help you. Does thyroid levels have to be under 2.5 TSH before conceiving? This is an interesting question.
Doesn't have to be, so you can still get pregnant when it's higher, but ideally, yes, I would prefer to see TSH 2.5 or under, because there is quite a bit of evidence that says that this is the optimum for pregnancy. Yes, you can. I've seen pregnancies happen with higher than that, and it can still be a healthy pregnancy, but especially for patients who are coming to speak to us, who people who have struggled or have problems, we want to make sure everything's optimized as best we can, so that this is not going to be an issue as well.
Thank you. Thank you so much, Dr. Sami. Unfortunately, we've run out of time. I can see that we still have more questions coming. So I do apologize if we did not have time to answer them right now at this webinar, but please send us to us and we will try to help you. We also can offer you a free 15-minute call with a nurse. But if you would like to speak to Dr. Sami today, we have an opportunity to schedule it with a 15% discount. And if you did not have a chance to grab the QR code, we can perhaps email to you the link to schedule a consultation so you don't miss this opportunity. But yes, I really hope that it was very informative session for everyone, and we've tried really our best to answer your questions. And again, thank you so much for joining, and I will wish you a good night and enjoy your evening. And thank you, Dr. Sami, for being so honest, so transparent, and again, your expertise is just spectacular. Thank you.
Okay, that's okay. It's a pleasure. And
Thank
good
you.
luck to everyone out there. I know some of you have struggled for a long time. It's been a long and difficult journey, but hopefully your time will come soon.
Yes, thank you so much, and good night. Thank you.